We have Gary Bell with us as our legal counsel, and he'll read us out of closed session.
There's one item to report out of closed session under item 5.2 of the closed session agenda. Medical staff credentials. The board unanimously approved the medical staff credentialing as presented.
Thank you. Are there any deletions, corrections to the posted agenda? Okay, hearing none, I'll move on to item 10, input from our audience. And this is an opportunity for anybody in our audience to speak on a subject other than what's on the agenda. So Martina, do we have anybody that's in the audience or any written comments from the audience?
I haven't received any written public comment.
Okay. Well, hearing none, we'll close audience input and go to item 10, input from our Employees Association. Is there anybody present from the Employees Association? Hearing none, we'll close that and move on to Safety First. And could I have a presenter for Safety First?
This is Jake Dorst. I am the presenter tonight for Safety First. I wanted to cover the recent warning that came from several federal agencies, FBI, HHS, CISA, about malicious cyber actors that were targeting the healthcare and private healthcare sector using some basically phishing software called TrickBot and Bazaar Loader. That's some malware that they were targeting a lot of the hospitals in the country. We were able to get prior alerts to this activity, knowing that how the TrickBot and Bazaar Loader, it sounds crazy, but yeah. Knowing how these malware worked and exploited systems, we were able to make sure that we were patched. We patched all our operating system software, made sure our firmware was up to date from our manufacturer. We were able to shut down any, Windows has a application that it can run in Windows 10 called PowerShell, which is the old command prompt. And we made sure that through our group policy that was disabled. We shut down a lot of the remote desktop protocols, RDP ports, and we're able to make some ahead of time changes based on ransomware best practices from the FBI and Health and Human Services. So we were able to do that. We routinely use a product here called Know Before, which helps us send out what we call white hat emails, basically fake phishing emails, to try to see who we can trick into clicking on those. We have a very good number here. Our end users are not either, they're not reading their email, or they're very wise to the ways of phishing scams, because we have a very low click percentage here. And when we have those things get clicked on, then we know who to talk to and who to help understand what ransomware and phishing attempts through email look like. So it's been a good software for us, and has really helped, I think, increase our diligence on our end users. So that is the Safety First for this evening.
Thanks so much, Jake. And it certainly is something that not only healthcare systems have to be aware of, but all companies and even personal computers are targets.
Yeah.
Do any of our other members of the board have any comments or questions for Jake?
So Jake, this is Art. Do you send those to board members?
If it's not everybody, so it's kind of targeted. We try to do certain amount. We don't want to blast everybody with those fake ones, but yes, yeah. Yes, we do. So
okay.
Stay diligent there, Art.
Haven't got the call yet.
So Jake, Dale here.
Are you aware of any other CIOs or having discussion with those who have had cyber attacks, and do you regularly check with other individuals or through an industry association?
Yeah, I was on a call recently with David Chow and some of those folks that have had these types of issues. Enlo got hit twice. So they got hit back in January with ransomware, and they were down for 3 days. And then they got hit again in February, like beginning of this month, they got hit and that knocked out their phone systems. So I also saw a CIO job posting for Enlo here recently. So I guess 2 times is the limit at Enlo. But yeah, it's definitely folks that have gotten hit now even get fined if they pay the ransom. So there's also, they don't want, which is kind of crazy to me because these are state funded actors that are doing this. And then our government fines us when we have these problems instead of kind of helping us get better. So that's something I've been trying to do in the industry to change that mentality. United Healthcare was another one that was a big ransomware, shut down a lot of hospitals.
Well, don't you encourage these bad characters if you pay a ransom? I mean, doesn't that increase the number of ransom attempts?
Yeah, and the increase in so you pay these ransoms in Bitcoin.
Yeah.
And Bitcoin is presently going like this price-wise. And so I think that's why you've seen a lot more activity with ransomware, because there's a lot of value in Bitcoin currently.
Yeah, okay.
And isn't it true sometimes it's better to pay them off than pay the price of having to have everything reinstalled in your system?
I mean, if it's we have backups, and I make sure that they're air gapped, as we call it. It's separated from our network. So we have physical backups of all of our data on hard drives that are then removed and sent off to a.
That's a leaving for the day, out of work.
So yeah, if you're going to be down and you can't get the data back, I know that there are some hospitals in the Cone Health system in North Carolina that they paid the ransom, but they still lost some of their data, their patient data.
One of the things that came out in, I guess, the trends that are happening in healthcare was this whole thing about putting your data in the cloud. What are your thoughts on that?
We're in the cloud.
Oh.
The cloud is nothing more than an offsite server somewhere.
Oh.
And
okay.
our Epic system is hosted in Missouri. So we're in that cloud.
Okay.
There's multiple backups. You can get into nuances of dispersed computing, where you have multiple copies of all your data spread out over data centers all over the country. I agree that that's kind of the wave of the future. That's where everybody's going, because it's cheaper to do it. Its uptime is much better. And frankly, those companies that house data, like companies like Switch that's in Nevada, they take security very seriously. Obviously, they put a lot of money and resources towards it that smaller organizations may not be able to afford. I think I have that in my board report talking about our SOC, Security Operations Center. So those things are controversial, but I think it's kind of the wave of the future.
Okay. Are any comments from our audience for Jake? If not, thank you so much. I'm sure we're going to be hearing more from you on the whole security of our system, especially as we keep expanding and adding more offices and things to us. So thank you again.
Thank you. My pleasure.
Move on to item 13, our acknowledgements. And Alex McLennan, our Chief Human Resource Officer, will do our Employee of the Month.
Yeah, this month, I'm really excited to announce Tamara Troxel, our practice lead in clinical service IM cardiology, as our November Employee of the Month. So here are a few things that Tamara's colleagues have to say about her. Well, Tamara certainly exemplifies all of Tahoe Forest values, she is truly eminent through her teamwork. Tamara is our go-to problem solver in IM Card, and regardless of the tasks she's occupied with, she never hesitates to provide her time and resources to keep things flowing smoothly. She is the epitome of teamwork that allows this office to provide optimal patient care that it does. Another colleague said, Tamara always exceeded any expectations in the category of quality, excellence, and stewardship, and is able to help us all better in these areas because of her support. We appreciate you and notice how you truly embody our health system values. You make us feel seen, heard, and supported. So if you can give it up for Tamara Troxel.
Thank you so much, Tamara, for your service and your commitment to the district. Our second acknowledgement is for our medical staff service personnel, and I have the good fortune of doing that acknowledgement. And in 1992, President George W. Bush signed a congressional resolution declaring the first week of November as National Medical Staff Services Awareness Week. And you go, so what does that all mean? Well, it means a lot to the organization. During the first week of November, we recognize medical services professionals, important members of the healthcare team who are dedicated to thoroughly investigating and verifying the credentials of healthcare practitioners. These women and men also have expertise in the areas of medical staff organization, accreditation, regulatory compliance, and provider relationship. So please give a hand out for our, or a hand up for our medical staff services. And I want to acknowledge three of our members, Dorothy Piper, Robin Ward, and Dante Thomas. Thank you so much for what you do to ensure that the physicians that come to our organization are qualified.
Yeah, I want to chime in here, Chair Wong, if that's okay. You know, Dorothy and Robin and Dante do a fabulous job, really at the forefront of making sure that every single physician, physician assistant, nurse practitioner, psychologist, acupuncturist, like the whole gamut is of the most highest quality to make sure that our community is cared for in the best way possible. So kudos to all three of you guys. Thank you so much.
Yes.
Thank you.
Any other comments from the audience about our medical staff?
I certainly have a comment. I don't want to take over the meeting, but I mean, I think it's worth mentioning by me as well. When we had a quarterly staff meeting, you know, I certainly brought this up, and Shawnee went out and got, you know, she's also our chief gift giving officer, and she got some very nice gifts for them. But you know, the term unsung hero is overused. These folks just, they're vital to the medical staff we have. They work so hard, many hours, you know, early mornings, late nights, because doctors' schedules are terrible. And so we always schedule mornings and meetings and nights, and they just do so without complaining, without any hesitation. I think they misnamed it. I want to go back and talk to George Bush if he'll pick up the phone. And I really think it should be called Medical Staff Services Appreciation Week, not awareness. I mean, it does raise the awareness, but I think it should be more of appreciation because they do so much. Vital part of what Shawnee and I do every single day, and certainly could not do that without them. So I'll quit blabbering, but one more round.
Hey.
Okay. Thank you.
And pass it on to your coworkers. And then we have another acknowledgement for National Nurse Practitioner Week. And I think Mary's going to do that presentation.
Yes, I am, Alice. Thank you very much. So if the first week in November was for the awareness of the medical staff and their services, the second week in November was National Nurse Practitioner Week. And so that would be the week of November 8th to the 14th. And the accolade that I have here goes on to say, nurse practitioners are highly skilled medical providers who bring a comprehensive perspective and personal touch to healthcare, blending clinical expertise in diagnosing and treating health conditions with an added emphasis on health management and disease prevention. Decades of research demonstrate the high quality of care that nurse practitioners provide to patients. Patients who see nurse practitioners as their primary care provider often have fewer emergency room visits, shorter hospital stays, and lower medication costs. By offering high quality, cost-effective, patient-centered healthcare, nurse practitioners are also a clear solution to the shortage of healthcare providers. So once again, Tahoe Forest Health System celebrated nurse practitioners for their contribution to our health and to the health of our community.
Thank you, Marion. Thank you so much to our nurse practitioners. Maybe Dr. Cole or Dr. Trudell, have you a sense of the number of nurse practitioners that we have now within the organization?
What I can tell you is we have 34 advanced practice providers, which include our PAs and our nurse practitioners. My guess is 12, 13 of those are nurse practitioners and the rest are PAs, but Dorothy, I don't know if you have the exact stats.
I just know that over the years we have had such a great need for them that we started off back in the day with 2. And now I feel that we must be up to at least 10 or 12 of them. Okay.
Yes, Sharon, I'm just pulling the report right now. It'll take me just a couple clicks here. So nurse practitioners, we have, I'm sorry, it's going to take me more than a click or two.
That's okay, Dorothy. I think the point is that we have an amazing medical staff. First, starting out with our medical staff services and making sure that they're qualified and high quality to get on our medical staff. And we have, you know, at least about a dozen of nurse practitioners along with physician assistants that help the physicians in our organization and our patients and community.
There are currently 12 nurse practitioners on our staff.
Thank you so much, Dorothy, for finding that information for us. Are there any other comments from our board members?
Great job. Great job.
All right, thank you. We'll move on to item 14, and that's our Medical Staff Executive Committee, and Dr. Trudell is going to present the consent agenda from their meeting.
Thank you. It's mercifully brief. We have one privilege form with changes. This is a sports medicine privilege form. The actual privileges are unchanged. The header was just changed to expand the scope of the number of clinics that this will be applicable. And then there's a new proctoring form. I think it was last meeting that you approved the conscious sedation, airway management privilege form for the outside clinics that are going to be using conscious sedation. So this is just the proctoring form, so the construct of how they'll get evaluated and checked off and assure proficiency.
Okay. Do any of the board members have any questions about the privilege form or the new proctoring form?
No.
Okay. Anything from our audience in regards to these two? And then hearing none, can I have a motion regarding the Medical Staff Executive Committee consent agenda?
Move approval.
Can I have a second, please?
Second.
Moved by Mary, second by Art, to approve the agenda as presented. Martina, will you do a roll call vote?
Sure, Director McGeary. Director Shamblin.
Aye.
Director King.
Aye.
Director Brown.
Aye.
And Director Wong.
Aye. Okay, so the meeting consent calendar for the Medical Staff Executive Committee is approved as presented. Item 15 is the consent calendar, and generally these are reports or non-controversial presentations, but there is the ability of anybody on the board or in the audience to pull any of these items. Do I have anybody that wants to pull an item? Okay, I guess I'm the only one. And I'd like to pull the chief medical officer board report and the chief informational and innovation officer board report. And we'll get to those under item 18. Item 16, items from board discussion. We have Dr. Cooper and Katie Clifford going to present the trauma program update.
Excuse me, Chair Wong, you have to vote on the remainder of the consent calendar.
Oh, I'm sorry. Could I have a motion to accept or approve the consent calendar, holding back the 15.3.4, the Chief Information Officer's report, and 15.3.5, the Chief Medical Officer Board report?
So moved. Dale.
Okay, it's been moved by Dale, second by Art, to pass or to approve the consent calendar with the two items being pulled. Martina, will you do the vote?
Director McGeary?
Aye.
Director Shamblin?
Aye.
Director King?
Aye.
Director Brown?
Aye.
Director Wong?
Aye. So the consent calendar with those two items pulled has been approved. Okay, item 16. Now you're on, Dr. Cooper and Katie Clifford, regarding the trauma program update.
Great. I hope everyone can hear me. And Martina has started our screen sharing. We are very excited about our update for all of you. This is Ellen Cooper. Katie Clifford is our trauma program manager and has done a tremendous amount of work to get us where we are today. We can go to next slide. Just to give a little bit of background, Tahoe Forest, as you all know, set on a journey to obtain level 3 trauma designation. The original plan was for our site visit to occur in September of 2020. Unfortunately, because of the COVID epidemic, the American College of Surgeons stopped all in-person site visits for all programs across the nation. And so there have been no site visits since March of 2020. With that, SSV, which is our local EMS agency, recognized how much work Tahoe Forest has done to get ready for trauma accreditation and offered us a level 4 trauma survey in the meantime while we're waiting for the American College of Surgeons to restart their in-person accreditation. The benefit to this was that level 4 trauma surveys are done by local EMS, so there didn't need to be any long travel. So SSV came and visited Tahoe Forest on October 9th and did chart review, looked at all of our programs, and had a lot of nice things to say about us, which was very appreciated. They were impressed at the volume of trauma patients that we see. It's a much larger volume than the average 25-bed hospital sees on a yearly basis. They complimented us on our team feel of the hospital overall. And on November 13th, they recommended Tahoe Forest to be a level 4 trauma center. And so we are now a level 4 trauma center. What does this mean for patients? This means that we're offering a standard of care for trauma patients that's recognized by the American College of Surgeons. It means that we review every single injured patient chart that comes through the emergency department. We do ongoing performance improvement program for all of these patients. It allows us to offer high quality, comprehensive, and compassionate care to trauma patients in Truckee and Tahoe, throughout the SSV area, and then to all of our more distant travelers. I just had Katie do this slide showing who gets injured, what are the mechanisms of injury for our patients. If you look at most trauma centers, motor vehicle collisions are their major source of trauma. And as you can see, we are special. We see a lot of bike injuries, ski injuries, snowboard injuries. We see falls. We do see our motor vehicle accidents and other issues. Ground level falls are common across the board, but our recreational trauma is different and makes us unique within the trauma system.
Dr. Cooper,
yes.
Would you entertain questions as you go here? Or?
Absolutely.
I have a question on this. I was fascinated by this chart as both a skier and a biker. I noticed ski, sledding, snowboard is all broken down. Those are the three, I guess, primary. But I would be curious to know in the bike, which portion is road riding and which portion is mountain bike riding? Is there any distinction that's made?
So we could break that down for you. I will tell you that it's about 50-50 mountain biking and road biking. And what we are seeing as an emerging issue is the e-bikes. Yes. We are seeing a lot of patients who are going faster than their bodies would allow them to go on e-bikes and are getting significantly injured. And the American College of Surgeons is thinking about splitting e-bikes from biking and putting it in with motorcycles due to the severity of injuries that we are seeing with e-bikes.
Yes, I noticed too that over in North Star, where they have a lot of mountain biking that goes on there, that they have a bike patrol similar to ski patrol. And I'm just curious how, it seems to me that so many of the ski accidents end up with an ambulance ride to the hospital. But if you're mountain biking way back in the mountains and you get injured, how do these people end up in the ER?
Well, that's an interesting thing. And that's one of the things that SSV noted with us. If you're in the bike park at North Star and get injured, you typically come in by ambulance. However, we have a lot of people who recreate, and a common story we hear from our severely injured patients is, you know, I was on Martis Peak. I didn't know how I was going to get out. I hiked out a mile or two. My friend walked my bike out, and then they put me in the back of the pickup truck and drove me to Tahoe Forest.
Right. Yeah. Interesting. Okay. Thank you. Well, I can tell you as an avid e-biker, it's growing logarithmically. And
absolutely.
And you're likely to see many, many more.
Absolutely. It is allowing people to recreate in a way that they were not able to in the past, which is excellent for them, but it does have some risk.
Right. I just hope I don't end up being one of them.
Yes, absolutely. We hope that too. Does anyone else have questions about this slide?
Yeah, Dr. Cooper, this is Art. Golf injuries?
That's ground level fall. That's not a golf injury. Yep, that's our elderly population who falls in the bathroom.
I just couldn't believe it was 12% golf injury. Okay.
Exactly. Yes. No, that's elderly people in general.
All right.
Yep.
Well, I wouldn't know about that.
No, definitely not.
Not yet.
Yes.
So Dr. Cooper, this is Alice. On the falls from heights, are we talking about contractors and builders, or what are we talking about there?
Contractors and builders. There's also the people who decide to clean out their own gutters, Christmas lights, all sorts of roofing issues, being on a ladder, doing some tree trimming, all of those issues can lead to fall from heights. And in fact, I would say that our contractors sometimes have a little more safety practice in place than people who are doing regular home maintenance.
And one note on that category actually includes any fall that's greater than ground level. So that could be off of a couple of stairs or off of a roof. So it's kind of like a broad category.
Oh, okay.
So
if you fell down the stairs, yeah, like if you fell down the stairs, then you would be on it.
Correct.
All right.
Okay, we'll move on to our next slide. So just to give you an idea of what we've accomplished in 2020, as we all know, it's been a challenging year, but I think we've made a lot of great progress. We initiated a monthly trauma case review offered to all med staff that gives them CME credit. And it is a multidisciplinary meeting where people can discuss care of the trauma patient and improve collaboration throughout the system. We have collaborated with our highway patrol officers to provide education on improving trauma patient transports. We have through a grant, we got a high fidelity mannequin that we have been using in simulations to help the community with their trauma care, including doing mock trauma activations in the emergency department and bringing it to local EMT classes. We created a blood task force to improve emergent blood processes throughout the hospital. And we've facilitated trauma-related educational opportunities for the ER and inpatient staff, and that's both physicians and nurses. Looking forward to the next slide. Next steps, as you go through your trauma process, you do get recommendations for opportunities for improvement. We have our list from SSV. These are all fixable areas of improvement, and we have already accomplished several of them. Our goal is to be ready so that when American College of Surgeons calls for sites to survey for level 3, that we will be first in line. And we are hopeful that we can spread the word about our trauma care throughout the community.
Dr. Cooper, it's Alice. Can you give us any idea of like the recommendations? Give us an example of what SSV recommended that we work on. And you said it was a fix already.
Exactly. Well, one example is that they thought that our some of our the way we were reporting out our radiology, this is a fine point, but this is an example of it, is that as we have overnight emergency reading of radiology, and sometimes it was hard for the reviewers to see what time that radiology review came back, because reporting that data is very important to make sure that trauma patients are getting quick, accurate radiology reads on their scans. And Katie has fixed that so that that data is easily available and accessible.
Okay, thank you.
Dr. Cooper,
Yes.
Cooper, this is Mary Brown. Could you tell us, now that we have achieved this level 4 certification, what will be different at level 3? I know that we will be able to receive a higher acuity of patients, but could you sort of fill that out for me a little bit?
Yeah. So level 3 trauma designation and level 4 trauma designation, in terms of what is offered, the level 4 trauma designation tends to be targeted towards rural small hospitals that may or may not have a surgeon available for their care. And so the idea historically of level 4 trauma centers is rapid stabilization and transfer. Level 3 trauma centers, the expectation is that there is a surgeon available within 30 minutes, 24 hours a day, and that you can take care of a higher acuity of patients and you can keep more patients in your hospital. I would want everyone to know that level 4 was not our goal. It was, we feel that we operate at a level 3 trauma center level at this point. It's just that it was impossible to get that designation at this time because of epidemic.
Right, thank you.
Ellen, is it unrealistic
Yes.
to think that we would ever go to level 2 or level 1? Do I assume those specialties aren't available?
Yeah, so level 2 requires neurosurgery capabilities. It requires a more robust intensive care unit. There are some other things that it requires, but you need, the big issue with level 2s is the 24-hour immediate availability of neurosurgery, which many level 2s in this region have challenges with, cannot meet on a regular basis. Level 1 has the same clinical requirements as level 2s, but that is a designation usually reserved for academic hospitals that have a significant training component and a large degree of research. So I think level 3 is where we will realistically live for the long term.
Gotcha, great.
Moving on, our 2021 goals is to become a level 3 trauma center. We have a plan to collaborate with Renown and their neurosurgery department to improve care for our head injured patients. One of the great opportunities in trauma designation is the ability to use your data to go out to your community and do education around injury prevention. And so we are hopeful that that will continue and that we'll really be able to dig into that as in-person meetings hopefully resume at some point. Dr. Jowers, one of our ER physicians, runs a winter injury review sessions with EMS and ski patrol. And we want to expand that year round for recreational trauma. And then we want to continue to raise the bar on our trauma care in our community. And those are our goals for 2021. And I think that's all I have if people don't have questions.
Thank you for entertaining our questions as you went through your slides. But does anybody on the board have any further things they want to talk to Dr. Cooper or Katie about?
You answered so many questions that I've had for a long period of time. I really appreciate this report. It was extremely helpful. And, you know, as a ski instructor and a bike guide to a lot of my buddies, I get asked these questions from time to time. And so it's great to have this information in my hip pocket. Thank you.
Great. I'd like to just close by saying that this has been a tremendous opportunity for this organization. And what is fascinating and exciting about trauma is it goes from pre-hospital to post-discharge. And I have had the opportunity to see so many people participate so enthusiastically, from the people who are registering patients to our radiology team, blood bank, OR, everybody who touches this has had a really can-do attitude and has really dug deep and figured out how to solve problems to care for these patients. And I think it's just a microcosm of what this organization does, but it has been so gratifying.
Yeah.
Good. Very good report.
If there's no, does our audience have any comments or questions? Okay, if not, thank you so much, Dr. Cooper.
I actually do, Chair.
Oh, you do? Okay.
Dr. Cooper, I'd like to take you on the road with this presentation because I think the community needs to learn what you presented. It was very compelling.
Call me. I'd be happy to.
I will.
Just
but I need Katie at my side.
Yeah. Don't do it on an e-bike.
Yeah, and don't do it between 10 p.m. and 5 a.m.
Yeah.
I know. Oh, we are locked down.
Yeah, we are.
I've never abided by any curfew in my life. I don't.
Okay, if I don't hear any other comments or questions, again, how much we appreciate what you and your team have done to get us to level 4 and onward to level 3. And we'll keep our prayers set and our fingers crossed that it happens sooner than later. Thank you again, Katie, for being the lead on this too.
She's been phenomenal.
Thank you.
Good job. Good job.
Our next item, 16.2, is our Wellness Neighborhood Annual Report. And we have Maria Martin to give us that. And I don't know if everybody got their booklet, but I was able to. So go ahead, Marie.
Unmute. Okay, hi everyone. I'm Maria Martin, Director of Community Health and Wellness Neighborhood. I'm really glad to be here tonight to share our annual report with you and answer your questions about it. So let's go to the next slide. Okay, so I thought I'd start with just a little bit of a background. So the Wellness Neighborhood was established in 2012, and that was after the health system conducted its first community health needs assessment. And we were kind of starting from ground zero with not a lot of services in place. And since that time, since 2012, over the past 8 years, we've really been able to establish a core team and a capacity to help us implement evidence-based programming to address the needs that are identified in the community health needs assessment. And the 4 needs that you see here, mental and behavioral health, chronic disease management, substance misuse, prevention, and wellness, have been pretty consistent in all of the 3 community health needs assessments we've conducted so far. So what the Wellness Neighborhood does, its goal is to support sustainable healthcare for the future, looking to the future through preventive care and wellness-oriented care. And we do this through collaboration and engagement. And we not only collaborate with different departments in our health system, but we collaborate with our local nonprofits, our county health departments, and even state level health services. This is a little snapshot of our expenses, I guess you would say. We receive the money to operate from a portion of the property tax revenue and the grants that we apply for and receive. And the vast majority of our funds goes to paying for our staff, the boots on the ground, the people doing the work, the education, the data analysis of our programs. We also, for fiscal year 20, 12% of our budget went back to the community in terms of grants. And these were for things that are gaps in services that we don't provide well. Two of our biggest grant recipients are Gateway Mountain Center that provides therapeutic mentoring for high-risk youth. This is a mental health service. And Sierra Community House, which provides a lot of outreach and education and support for our Hispanic and low-income population. And then the last 10% of our budget went to overhead, rent, marketing, things like that. So the wellness neighborhood for the health system is really a bridge between the community and the health system. We bring information from the health system out to the community, and we also bring community members back to the health system, specifically in terms of establishing that relationship with their primary care provider. Some of our strengths are our ability to be flexible in response to need. We saw that a lot with the COVID epidemic, you know, really having to change how we do things and also the services that we offer, what the community needs, what types of education and resources they're asking for. But this ability to be flexible is also really important in terms of grant funding. We can go after funds to implement programs where the funds kind of give us the seed money to work out the details of the program, the workflows, how it's going to work within the health system until that program can become sustainable. And I'll talk a little bit more about that later. And then we try and look at our needs and our health issues with the lens of health equity, addressing disparities and cultural diversity as well. We've been spending the past couple of years a little bit more energy on consistently getting information out about our services. So we get things out in a variety of different areas, you know, with the way the health system promotes itself, and we use those same areas. The smaller image is a sample of an ad you might see in the Sierra Sun, and the Authentic Wellness is an example of kind of our flyer template for that we do in the community. You know, we also use our community partners a lot to let people know about what's coming, you know, just getting the information out. And new is kind of information on the radio. And that's actually from anecdotal information from participants, that seems to be a good way to get information out as well. And all of this type of outreach is really leading to a much more consistent participation in our programming and more people reached, which is great. Okay, so now I'm going to go through the annual report. I'm just going to be touching on some highlights, but I'm happy to answer any questions about any of the information in there. When we do our annual report, we kind of have a really broad base of work. And so we try and pick a few things in each area to really highlight in each year's report. But the Wellness Neighborhood doesn't, you know, just do one thing. We're working to support the health system, primary and specialty care, and the community at large. So for when we work with the health system, you know, we talk about the needs that we, you know, from the community health needs assessment. That's a big component of our role. The funding that we go for, and then if we're successful, we manage the funding. Leading and collaborating with local, gosh, lots of different agencies. And the idea behind that is really that we're all working towards the same goals, but with multiple agencies and county and health departments all working together on immunizations or dental health or whatever, we can achieve more than we would if we were just doing this on our own. And then ultimately, we want to develop sustainable programming for the health system. So the project I was going to highlight this year is the Zero Suicide Initiative. And this is an evidence-based program. It's actually international. And it's really about how we take care of suicidal patients, how we identify people at risk for suicide, the policies and procedures that we have in our health system, and the level of training that our staff has that helps them feel comfortable and confident in dealing with these types of patients. So as a health system, we've been impacted by suicide. We've been impacted directly with the patients that we take care of, even with our staff. And we know that suicide is a really big problem in our area. In 2017, injury-related deaths, suicide is an injury-related death, was the leading cause. Suicide was the leading cause of death in 2017 in both Placer and Nevada County, which is kind of surprising. So what we did is we convened a really motivated and wonderful leadership team to work on this project, and it has representation in areas throughout the health system. We were also fortunate to be able to partner with the state of Nevada, who is launching the Zero Suicide Initiative in all their health systems. And so that partnership has given us some really great training resources. We participated in Zero Suicide Academy and is really helping us along this process. So our leadership team kind of came up with this 3-year plan of how we'd like to launch the program. We are just finishing up year 1, which is focused on really looking at all the policies we have, kind of compiling them, making them more consistent across all departments, and starting to implement a communication plan. And then as we go into next year, we're going to focus on staff training and refinement of our plans and monitoring how we're doing with the screening of patients. And then this slide, so a part of our communication plan is we started an intranet page to really have a place where staff can go to get informed about where you can find more resources, what kind of trainings are available in the community for people that want more information on their own. What is zero suicide, things like that. And zero suicide, when we look at it as a health system project, it's really for every employee in the health system. It's not just for people that are taking care of patients, because you never know when you might come across someone who is having trouble and maybe kind of at risk for suicide. And if everyone in the health system is trained to be able to identify when someone may be having issues, if everyone feels comfortable approaching that person, whether it's a family member, a friend, a neighbor, or a coworker, and knowing what the next steps are to get that person the care they need, we will have safer suicide care. Okay, and then in terms of how the wellness neighborhood supports primary and specialty care, one of our main things is being a referral resource, a place where providers can refer their patients to get the needed support to help them improve their health. So again, we're developing and implementing sustainable programmings. We also look at quality metrics that will improve care and also improve population health. So I thought this would be a really good example of how the wellness neighborhood works with other departments to meet patient needs. So when someone is making a referral to wellness in Epic, all those referrals go through the customer care navigators. And in fiscal year 20, they navigated over 2,300 referrals to wellness, averaging what was about 200 referrals a month, which is up from about 150, which was the year before. So we're really expanding our referral resources and the providers that are referring, which is great. All these different circles on here are different departments that provide these kind of referral education, outreach, coordination for patients that providers can refer to. The wellness neighborhood programs are typically free or at very low cost. And they're focused on our 4 main objectives that are identified in the community health needs assessment. The Center for Health provides fee-for-service wellness resources for anyone, for the patients or the general public. The PRIME program is a targeted grant program that is targeting the Medi-Cal population around blood pressure control, chronic pain, behavioral health, and diabetes. We have our new behavioral health department in there because some of the referrals go straight to them, but sometimes there may be some things that where other people can provide additional support too. And then care coordination. A lot of referrals to wellness, some of those high-risk patients are managed by care coordinators, and the other wellness programming can provide additional resources for them. Okay, we also develop and implement sustainable programming. And this is our integration of behavioral health into primary care programming. I think this is a really good example that supports all the target areas, not the health system, the primary care clinics, as well as the community. So we know that depression goes undetected in more than 50% of primary care patients. And so we applied for a quality improvement grant to implement universal screening in primary care. So we're screening for depression just like you would screen like blood pressure every time you come in. It's just something that we're checking. This program also, by the way, aligns very well with the Zero Suicide Initiative because this is our screening resource out in the outpatient arena. So if we kind of follow this around from left to right, we applied for this grant. We're receiving $200,000 a year for 3 years to integrate behavioral health into primary care. The majority of the grant funds are to provide staffing, which is a resource to be able to address the needs of patients that are identified at risk for depression. Because once you start screening for depression, you know you're going to find more cases than if you don't ask for it. And so that the grant funds the behavioral health intensivists completely and partial for the clinical psychologists and the promotor and the others. And what we've been working on this first year is really developing a consistent workflow that will work in all clinics that will help us to increase the number of patients that we screen for depression preemptively. Actually, it was really great that we had implemented this program because with the COVID epidemic, we have seen a dramatic increase in referrals for behavioral health. And so we had these resources now lined up and ready to go. But at the end of fiscal year 20, 51% of the referrals to wellness were for behavioral health reasons. And we also, when looking at the referrals, we saw that there's an increased need, an increase in people at risk for depression who are female, low income, and are Hispanic patients. And even though we're just really kind of just at the very beginning of this process, we've already been able to document some improvement in terms of the follow-up for patients at risk for depression, so that fiscal year 19, 63% of patients who were screened high at risk for depression had follow-up, whereas right now we're at 77%. So that's a good start. And we've got lots of room for improvement to go. And then the Wellness Neighborhood also supports the community by providing education and outreach. We try to help people that are healthy stay healthy, and we try and improve the quality of life for those with chronic disease. And we also spend, we address health equity through the work of our community health advocates and promotores. These are bilingual, like community health workers who provide culturally appropriate education and advocacy for all our Hispanic patients. Okay, so achieving well-being and optimal health, this is really an active process. This is the process of making choices to support health. And so we have a variety of education and outreach opportunities. We touch a lot of people in the community in this way. In 2020, we had over 2,600 events and reached over 19,000 people. A lot of our typical outreach things were curtailed as of March, especially things in the schools where, we're just shut down. We didn't do big events, but we did rally, and we went and looked at different ways of doing things. We've switched to virtual platform for most of our education. And we were able to continue to offer services for people that way. So we're addressing people with chronic disease in our self-management programs. We're looking at families and pregnant women and getting people off to the right start in the beginning. we were doing a lot of community screenings before COVID, but we are back to offering the affordable labs again, but we're not doing out community blood screens or glucose screens at this point. And then we do a lot of talks and challenges, both for our employees and the community at large. And Harvest of the Month and BFIT are longstanding programs where we provide education on nutrition and activity in our local elementary schools. We also found that the pandemic really intensified some of the disparities we see that, you know, certain people are at much higher risk for disease than others. So the data in the square is looking at the state of California, where 39% of the population is Hispanic, but it represents 61% of the COVID cases. And for Placer County, 15% of the total county's population is Hispanic, yet 35% of the COVID cases as of June were in this population. You know, and we were seeing this as it was kind of happening. And so we knew that we had to do some things different to try and get information out to this really high risk population. So we advocated for Spanish language messaging on our social media, specifically around COVID issues. You know, how to take care of yourself, how to get tested, how to stay safe with your family. We also advocated for consistent signage throughout the health system. It's you know, this time with a pandemic is stressful. And when we change how we do things, we want to make sure that the notifications are in both languages so that people can act appropriately. And our promoters worked to dispel some COVID rumors whenever they had interactions out in the community, to let people know that it was safe to come to the health system, to tell people, you know, what does it mean to quarantine and how to do that safely. And then at the end of fiscal year 20, we started having conversations with Nevada County Health Department and how we might be able to support them in Spanish language contact tracing efforts. And then we also focused a lot this year on just making sure that we were having culturally appropriate language. So this was the first year that we offered the diabetes prevention program in Spanish. This is a year-long program for people who are at risk for diabetes but do not have it yet. So our Spanish language cohort completed the first year. That first picture is from their graduation party. And then we have, you know, bilingual services for perinatal care coordination, for lactation counseling. Our self-management classes are offered in English and Spanish. We have video monitor slides in Spanish as well. And we offer simultaneous translation when we do community talks. So when we can get the word out to people, we try and meet as many people's needs as possible. Another way we tried to do some appropriate, you know, address different needs had to do with the virtual education platform using Zoom, something like this. People really struggled with that initially for, you know, if they weren't comfortable with a computer. So we had to develop some special guides to help people kind of with pictures on how do you hook up Zoom with your phone so that they can still participate in the self-management classes. And then just wanted to give a little highlight of what we're working on right now as we look forward to this next fiscal year. We are planning for our next community health needs assessment in the spring of 2021. It would have been planned for this past fall, but we decided to postpone it with everything going on. And I think that was a really wise choice. And for Zero Suicide, we're going to be focusing on training and policy implementation. Our quality metrics, we're going to continue to be monitoring screening for depression in primary care and hoping to increase the percentage of patients screened. And we're going to keep focusing on our Prevent T2 Diabetes Prevention Program metrics. This year, we received full recognition from the CDC for the program, which means that we met all the stringent requirements to get that recognition. For health equity, we do now have a contract with Nevada County, and our promotoras are taking referrals from them for doing contact tracing. If we have any local Spanish speaking community members that test positive, they work with all the contacts that they may have to try and keep people safe and reduce the spread. And then we also just in the past couple months have a promotora that is going to be working a few hours a week at the Cancer Center. And so that's a really new service for them, and we're really excited about that. And then the last thing we're experimenting is education with video content. So I mentioned when we were looking at our outreach activities, we're out of the schools. You know, we can't go in there, and we have typically done a lot of school-based education, either with our own staff or we train volunteers to go into the school. So we've been experimenting with short videos that the teachers can use with the remote learning. And we're having some success with that. So we're going to keep working on that. Okay, that's pretty much my information in a nutshell to present to you. And I'm just wondering if you have any questions for me.
So we're open to the board.
Yeah, this is Art.
Okay.
Yeah, I have a question, Maria. Two questions, actually. How many staff do you have? And do they work just for you, or do they work with the hospital also, or how does that work? And secondly, on the 3-year grant, when is that up and what happens when it's done?
Okay, so well, first we'll start with staff.
Okay.
So on the last page of the of our annual report, we list how we work with staff. So we have some dedicated staff in the wellness neighborhood. I think we have 5 FTEs that are designated to wellness, but we work in partnership with a lot of different departments. And so, and we share staff across departments. So the same wellness dietitian that may work part-time for me also sees fee-for-service clients at the Center for Health under a different department, things like that. So there's a lot of people that are helping to get this done. It's not just a few of us. It really takes a big team to get this done, but there's little bits here and there. When we run affordable labs, we have, we use lab staff and registration to assist with that as well.
Okay.
And then as far as the 3-year grant, we just finished up our first year, so we have 2 more years. And the goal of the grant is to, is that the employees that are being funded by the grant, the behavioral health intensivists, will become a reimbursable employee in the rural health clinic. And so that is our goal, is to really work out the workflows, and then she will be able to bill for her services in the clinic.
Good. All right, thank you.
Mm-hmm. Any other questions from the board?
Yeah, Alice, this is.
Go ahead, Mary.
Yeah, Maria, thank you so much for the work that you do. This is Mary speaking. It seems to me that in listening to your report this year that you really have concentrated and expanded on your Spanish-speaking programs. Is that correct?
Yeah, we've been doing that all along, but we're really trying to be very thoughtful and consistent and try and make things accessible to everyone.
Uh-huh. I'm wondering, you said that you do some outreach on the radio. Are you including Spanish-speaking stations in terms of your radio outreach?
You know what, we have not, and that's something that we have, we would like to look into. There are a couple of really popular Spanish-speaking radio stations, and they reach, you know, the KTKE station is just for our local listening area, but the Spanish language ones reach into Reno, and I don't think that that would be a problem. Even though we're kind of broadening our area, I think a lot of the information that we have out there might be interesting to other people too.
Wonderful.
So it's something we can look into.
Great, and we will, you know, certainly look forward to your next needs assessment. You say you're going to start that in the spring. By when might that report be available?
Well, right now we're planning to do the assessment, like the survey, in either March or April. We're kind of still working out the details for that. Usually it takes probably about 4 weeks of survey time, you know, when they do the phone surveys, and then to compile the data. I would hope that we would have everything compiled and ready to report in the fall of 2021.
Wonderful. We'll look forward to it. Thank you.
Mm-hmm.
Dale?
Yes, Maria, I've got a couple of questions for you, if I may. In past reports of the wellness program, school-age dental screenings have been a part. I didn't hear you mention it tonight. Is that something that's been put on hold, or is that still going on?
Yeah, it's on hold just because of COVID. So yes, we can't go into the schools. You know, we use the volunteer local dentists to do the screenings. They're quite popular. We weren't able to do that. We did provide some information, toothbrushes and things like that this year, but we couldn't do anything face-to-face.
Gotcha.
But we will continue with that once we can.
Yeah, okay. Increased depression, I assume, is directly or indirectly related in some cases to COVID, whether your loss of the work or the illness itself. And if that's true, do we assume that with a successful vaccination, that depression may mitigate rather quickly?
I don't know if I can answer that in terms of, the diagnosis of that, but I do know that what we are seeing with the pandemic is that people feel more stressed because of social isolation and just the other circumstances related to the pandemic, loss of work, having to homeschool when you weren't planning on it, and trying to work at the same time. And so we're seeing a lot of that. Now, I know that behavioral health department has seen a lot of relapse in terms of people that have substance misuse diagnoses or those types of things. And so that's exacerbated some of those conditions too.
Yeah, okay.
Maria, if you don't mind, this is Dr. Arth. It's been a real pleasure. Hi to everybody. I haven't seen you in a while, but
Dr. Arth.
It's been a pleasure to work with this group. Dale, the answer to that question, I think, is multifaceted. It is likely that the population won't be vaccinated for nearly another year. Yeah. So we've got a long winter to go through, and that we're already seeing, even though I'm only working 2 days a week and seeing well children, I can see the change in the amount of mental health and our need for mental health. And it's been, ongoing and going to get worse. So it's a real issue. Just while I'm on, I would just support that. I'm really proud of Maria and that whole staff of doing a great job of following all of this. Obviously, vaccines is the main issue that I've taken up prior to this. And I'm proud that we were able to get through the vaccination mandatory for hospital workers, which I think was very forward thinking, because I think it also puts out that vaccines are safe. And the whole struggle, part of the issue, Dale, is getting people vaccinated. If it's still 40% of people don't want to vaccinate, getting that to turn around is going to be very interesting. Yeah. So I'm now going to join into that COVID vaccine committee, which is actually a part, I guess, from the vaccination committee, but that'll be very interesting to see the rollout of that. But I applaud that we've gotten Chelsea Roth on as the pediatric coordinator for mental health, because we were struggling like crazy for pediatric mental health, and that's been a huge addition. So I really want to thank the board and everybody for making that happen.
Yeah. Maria, one of the joys of growing older is you get a Medicare annual physical. And my primary care physician, Alice, I see you chuckling too. My primary care physician, Rick Ganong, every year lately has been asking me questions about depression, mandated. And I'm just curious to know if you include those Medicare questions as part of the depression screening.
Yes, we do. They're asking you the same questions that we would be asking in terms of the initial screening, the PHQ, in primary care. So all patients are asked the first 2 questions of the PHQ. If they score high, then they continue on with the next 9 questions. Okay.
And then just one last quick comment. I live in Tahoe Vista, very close to Kings Beach, which has a very large Hispanic community. My wife and I both noticed that as COVID was starting up over the summer, people were getting the message and wearing masks, particularly in the large Safeway store there at the corner of 267 and North Lake Boulevard. Mm-hmm. But oftentimes people without masks were part of the Hispanic community. I can tell you now, everybody in that store is wearing a mask, including, so the message is getting out to even the Hispanic community to mask up. And I assume if you mask up, you also take other precautions because you know more about the COVID. So
yeah,
whatever you
do,
working.
Yeah, I think information is getting out for everyone to have ways to be safe in the community, and that's really good. I do want to make one addition. So Lizzie's on the call too, and she helped me out, reminded me that we did do some dental screenings in the fall of 2019, which is at the beginning part of this fiscal year. So we did 320 screenings before we were stopped down. We would have done another round in the spring, and we would have done another round this fall, but those were canceled.
And I would add in as well that the pediatricians at least have the fluoride that we can apply to teeth, which has been shown to be a pretty good preventive thing. So certainly I'm trying to make an effort for our clinic to be doing that as much as possible.
Great. Thank you.
Maria, I have a question, or I have two questions. One, for the Zero Suicide Roadmap, and you're going to be doing education and policy development. It's a national or international program, you said. So are there templates and best practices that are supposedly included in your development as well?
Yeah, there are definitely templates, and there's a whole different feature components that we are including as we go through, and we're following the Zero Suicide information, but the policies and stuff are really specific to the organization. Mm-hmm. And so what we've been doing is Ashley Davis is kind of heading up our policy group, and she's been reaching out to all the different departments to find out their suicide related policies so that we can kind of be more consistent and educate everyone across the board as to what those policies are.
And my other question is, since so much is being done virtually on Zoom, and I know that that's a challenge when you have the computer, but when you're looking at a population that you're serving, do you have a sense of people who are struggling because number one, they don't have it, or number two, they can't afford the service? Or are we doing anything about those particular, especially if they're the high risk ones?
Mm-hmm. Yeah, we do run into some issues around that. And what we try and do is, that's why a lot of the wellness neighborhood programs are offered at free or very low cost. So that when I guess, let me see if I can see an example. We just try and connect people with the best resources that we have to get them the information that they need. So if someone's referred for a nutrition consult, which would normally be through the Center for Health, sometimes we may find that if they're on Medi-Cal, they may also qualify to be a Prime participant, in which case we can support them through that program as well.
Okay.
We also offer, general education out in the community, and our staff, our dietitians are great about, tailoring the content based on the people that are there.
Okay, thank you. Is there any questions or comments from our audience?
If I can throw in a question for you. First off, Maria, thank you for everything you and your team do. Incredibly valuable asset for the community. Can you share some of the ways beyond the community health needs assessment that you're measuring impact? How are you tracking the outcomes of the efforts that you guys are doing?
Well, in our individual efforts, we do like evaluations, pre and post. Diabetes prevention program, we're looking at activity records, weight loss, things like that. Self-management classes all have pre and post tests, so we can get feedback on people's knowledge. We have a lot of testimonials from, people that have participated in programs. Other areas for information is we look at other community surveys too. So like for youth information, the school district does a Healthy Kids survey every 2 years. This year, we've got some more behavioral health information because the Cats Amsterdam Foundation, that's a part of the Vail Corp, has done some surveys in mountain communities where they have resorts. So we've gotten some information from that as well.
Very cool. And then second question, what are some of the greatest limitations you face in doing what you're doing? I know it's incredibly hard work. Where sort of your greatest need is maybe a different way of asking it for you and your team.
Yeah, well, it kind of goes along what Director Wong was saying. I guess one of our biggest frustrations is that when we have a challenge offering a service because someone can't afford to pay for it. Okay, I think we're going to be able to resolve some of that with the development of our rural health clinics. Although medical nutrition therapy, and this is probably the most common one, nutrition is our second biggest referral after behavioral health. We don't accept private insurance for nutrition counseling, and part of that has to do with being a critical access hospital. And the other part maybe has to do with, we just don't have the contract set up to do that. But we have an option with the rural health clinics of providing some of that medical nutrition therapy in the clinics. It's not a reimbursable visit, but it can be included as an expense in the cost report. And that's one avenue that we've been trying to explore.
And this is Dr. Arth. I would also, comment that the non-reimbursable parts are the biggest challenge. So that from pediatrics especially, we send a lot of overweight children who need not only an exercise program along with the nutrition, but they need the ability to penetrate the community, actually go to the houses with the promotoras, convince the entire family, because a lot of times it's transportation coming in. Mm-hmm. On the mental health arm, because it doesn't self-reimburse. I mean, that's part of the reason that enough people don't go into mental health. But that we're doing the best we can. But boy, those are some of the areas. I would comment that one of the other measurables we've done is that taking the PHQ-9 test, which is our screening exam for depression, it started in primary care. It's going to come to pediatrics, but we'll do that with every visit, and we are measuring how much that's happening, and it's definitely on the increase. So.
Are you finding you're able to staff, especially around the areas of mental health? That's something I'm encountering sort of nationally, is there's just a massive shortage of people. Are you encountering the same?
Yes, and I think Eileen Knutson could talk more about that. But yes, it is hard to find qualified professionals to work in behavioral and mental health.
It was about a year ago that I went to a conference where the chairman of the department at Harvard said there is just not enough people going into it because of the reimbursement issues.
Thank you.
Okay. If there's,
I just have I've been thinking about it as I've been listening to this, and I think we're going to have, we talk about COVID and the like, and I happen to have been talking to my daughter, who's a teacher, and talking about the trauma that is happening with these kids through this whole pandemic, and hopefully there won't be lasting effects. But we forget how important it is to be able to go to school and to get out of some of the household situations that are out there. To get away from the big brother who bullies you all day. Just those kinds of familial things that are going on, parents as teachers, and the stress around that there's just this whole new bolus of kids that are traumatized through all of this in gross and small ways. And I think that the sooner we can get this vaccine out there and get back to normal, it's going to be so good for these children.
Yeah, one thing, you're talking about trauma. One other area that we're exploring into is, I don't know if you're familiar with the term ACEs, which is adverse childhood experiences, and how that impacts health as the rest of your life. And so there is a grant opportunity that we are looking into about how that might help us support us in doing some of those types of screens.
And I've gone through the ACEs training, and I would suggest that it's a very good thing. It actually, one of the big people is our Surgeon General for California. So it is a very viable and good program we could lean on.
Well, thank you. Just a comment.
Mm-hmm.
Well, thank you, Maria. Thank you, Dr. Arth. And we'll be looking forward to hearing more about how we are getting a healthier and healthier community over the year. So we look forward to that. And thank your board and your employees for the work that they do to help us.
Thank you so much for the time.
And then we'll move on to 16.3. We're going to have a COVID-19 update from both Harry Weiss and Judy Newland are going to work together in giving us that.
Good evening, Chair and members of the Board of Directors. Several of our team might participate. I'll do part A and just cover some really important high-level items, and then Judy and others may assist with some other important aspects. Just to kind of give you a little bit of an idea on this accelerating disease that's been around for more than 9 months, maybe as early as December in some areas of the world. On November 13, worldwide was the highest individual positive lab test day so far. We'll see, it's very likely that date will be breached and later dates happen. In the United States, 11/13 was also the day, just a few days ago, and we'll see where that gets breached as well. California is back on July 22, and so that peak day on positive lab tests is certainly at risk as well. The state of Nevada, just next door, November 14, was their high day as well. Another angle that we've been looking at is kind of that reproduction factor or R factor with the disease, and I've been watching it for several weeks right now. And about 4 or 5 weeks ago, California was at a 1.09 level. You want to be below 1.0 as greatly as you can, and we've jumped around a little bit, but then more recently we've been up in the 1.14, 1.15 level. Nevada, by contrast, just a few weeks ago was 1.09, and today it's 1.22. So certainly quite a bit of intensity there. As we look at the entire United States, 49 out of 50 states are in the red zone with a reproduction factor well above 1. The top 5 states right now as of today, and this moves around, is New York, DC, New Hampshire, Washington State, and Vermont. Maine was up there in the top number 1, but it has fallen back just a little bit. I wanted to switch a little bit to our local region and talk about some global issues. So over the last 9 months, our region, this would include Western Washoe County, Eastern Placer, and Eastern Nevada County. As of today, we have about 792 positive lab tests, so rounded off to about 800. That would equate to about 88 positive patients per month, or about 2.9 new cases per calendar day. If we just come forward to the last 4 or 5 days or so, we're seeing that 2.9 positive lab tests per day be up in around the 18 per day average, with a low of maybe 6 or 8 and a high of 32, but an average of about 18. So considerably an uptick in positive lab tests in the last few days. Our numbers of employees who have been affected has been creeping up. It's up to now 59. And today, as we look over the span of these months, we had a peak inpatient day of rule out plus inpatient confirmed that was 7 on a day in early April. We reached 8 on June 30 on a single day. And then we were quite a bit lower than that for the days since June 30th, except today, for example, we were 7 again today with rule out and confirmed cases too. So far, it looks like if we look at rule out and confirmed inpatients that have been tested, about 294 inpatients. I'm going to talk about some global strategies that we're really in support of for our team and our community, and then Judy and others are going to fill in some other really important aspects as well. So our team has been really proactive and supportive of Therapeutics, all those best practice therapeutics that are available. I think even including the new Eli Lilly antibody cocktail that has just received approval in the last week or so. And I think our team may talk about that. We, of course, had convalescent plasma and a variety of other, and remdesivir and so forth. Another strategy that our team has talked about quite a bit is, it is really important as you look at the vitality of this disease over the last 9 months, it really shows no desire to weaken at all. And as a layperson, I really think about polio, which is very dear to Rotary and others out there. And the only way we really brought polio to a halt was through vaccines. The only way we did it with smallpox is through vaccines and so forth. So my subjective impression is that you know, having a very robust vaccine program is really important for our area if we really want to have a normalcy return here in our lives and the health and so forth. So our team is really going to be collaborating very closely with at least 3 counties, Washoe, Placer, and Nevada counties. And we're estimating there's going to be quite a prescriptive flow as to who's first, second, and third, and so forth in that. But we really would like to do something that is very significant for our community. It's kind of a once in 100-year opportunity to really engage in a public health setting with this vaccine endeavor. And again, it's going to be on a voluntary basis, but I think it's just so important for our community to have, because the only way I think we're really going to bring this to a halt is either you've got to have herd immunity, which means a lot of people have had the disease and they've successfully overcome it, or we have a very high prevalence of a vaccine. So we want to be a prudent player in that as well. As I've been talking with the media on an increased basis just in the last few days, you know, when we just scan our organization and see an increased presence of detox patients in our ICU, this was something I talked about back in March publicly, that we really want to urge our community to really have healthy living appetites relative to food and drink, and really try to minimize those alcoholic beverages, but also moreover really have a plan that focuses on a positive mental health trend line and physical health as well. And if they're struggling, that they immediately seek treatment, et cetera there. So there's a clear sense, as I've talked to many different stakeholders, that having this health dilemma continue for 9 months and not having a near-term light at the end of the tunnel that this will be over with, like, for example, just catching the common cold, that it's really wearing on many individuals out there. And as you saw in our earlier report, you know, mental health referrals are elevating extensively as well. So we've really shared with our community to the best of our ability. We really want individuals to timely pursue their healthcare needs. If it's physical medicine, if it's mental health medicine, we're here for them. And those are just some high levels, and I'll turn it over to Judy to fill in a tremendous amount of other important aspects on COVID-19.
Thank you, Barry, and thank you, Board of Directors. I'm going to give a presentation and just speak about some of what is occurring in our health system in response to the current surge. But actually, before I start, I really want to give a thank you to our frontline healthcare workers, both at Incline Village and Community Hospital and Tahoe Forest Hospital. You know, every day they greet the patients. Every day they're there for them. And I know we all really appreciate all that they're doing. So just a reminder, as we go through this, I also want to just kind of go through some lessons learned. We did when we started this in March and April, and I think one of the things we really focus on when we are preparing for the surge is really remembering that, you know, really our goal is to keep everybody safe. And so today, knowing that in our health system, you know, masking, washing your hands, and social distance are key. And so we work with our staff daily to make sure that we mitigate those issues and to make sure that when patients come through the doors, they feel safe, and our staff and our medical staff. So we did begin this summer recognizing that perhaps we would have a surge this fall and winter, and we have. And so I do want you to know what we have prepared and what we have put in place. Regarding our respiratory illness clinics, if you recall, we have a respiratory illness clinic we put in place in March and April in Truckee, that an outdoor drive-through that's still in place, and an Incline Village Community Hospital. This week we opened a pediatric illness clinic at Tahoe Forest Hospital. It's actually indoors. And the purpose of that, again, is to see any pediatric patients that are symptomatic for COVID symptoms. Additionally, in about the first or second week of December, we will be opening an adult respiratory illness clinic drive-up in Tahoe City. So we want to make sure that we service all of our region, and really in the winter, we have a lot of visitors and community members in the North Tahoe, Tahoe City area, so there will be a clinic available for them. The other thing we have been working on is testing, COVID testing. And so I want to make you aware what we have available within our district, and then where we have to go outside our district. So we've talked before about the point of care Rapid ID Now testing. That's actually a test that has to be done within 1 hour of swabbing. We provide that at both Incline Village and at Tahoe Forest Hospital at the Respiratory Illness Clinic. I will let you know, we recently actually took one of our equipment, and actually it is at the Respiratory Illness Clinic. So we hired a staff, and they are there all day long running that test for the individuals, both the adults and the pediatrics that come through those stations. And then we're able to give the results to the community member or employee at the end of the day.
Judy, excuse me, do you want questions while you're doing this, or?
No, you can go ahead and ask, that's fine. And I may not, and I will be using my peers, other executive team members to help answer. So please go ahead.
So does this continue to be for patients who are symptomatic?
Yes.
Okay.
Thank you for the question. So the BioFire is best used for symptomatic, and we have made a decision we have a 99% positive rate on that. And so we use it for symptomatic only.
Okay, thank you.
Thank you for asking. I should have said that. So great question. The BioFire, if you recall, that is a piece of equipment that we were able to purchase through donations from our Incline Village Community Hospital and Tahoe Forest Health System. And there's one at Incline Village and Tahoe Forest. It has a 21 respiratory panel plus COVID testing. And that we are able to use. And really what we use that for is when somebody comes in and has multiple symptoms, we know that you can have a cough, we know you can have the sniffles, you may not have COVID. So that allows us to do a differential diagnosis on those patients. We also have been using testing with Renown. They also has a test that we can get back in 24 to 48 hours. And you probably ask, well, why do you need Renown's testing? Well, sometimes we don't always get the supplies that we need. So the Abbott ID Now, though Abbott has been good to us, there's a lot of people in the nation that wants that test. And so we still continue to use Renown for testing patients along with our pre-surgery patients that are asymptomatic. That is one of the benefits of Renown's testing, and others is that you can do asymptomatic testing and it's very accurate. We also are, because of the surge that we're seeing, we are beginning now going back to using our a specialty pharmacy called Quest. We've have contacted them and working to get those turned around within 48 hours because we know that we're going to need to increase our swab testing. For asymptomatic testing, just a reminder, the Placer County test site across from Tahoe Forest Hospital is available, and we recently have expanded their rental space from us. They want to be able to have what they call more lines, still the same staff, but if they can get more patients in, individuals in and out, they can be more successful in getting patients scheduled faster. I think they're about 6 days out. And then again, Washoe County has test sites in Reno. Recognizing, again, the importance of trying to meet our community needs and being able to keep things locally, we actually are looking at leasing some equipment similar to what Renown has. Ideally, we'd like to have that here in 4 or 5 weeks, and we'd be able to do our on-site testing, and that helps us with asymptomatic testing. So that would be really beneficial. Before I move on, I wanted to ask Dr. Cole, is there anything you'd like to add to that?
No, you did a terrific job. Thank you, Judy.
Thanks. I'd like to go on to treatments, and if you recall, we have educated regarding the clinical management team. That is a group of physicians, nurses, pharmacists, and respiratory therapists that we meet weekly or every other week that stay current on the treatment of COVID. So I do want to let you all know that we do have remdesivir here that is for inpatient treatment, and we are able so far to keep that that medication on site. So that's been very successful. Harry alluded to the approval of the new antibody cocktail, hope I'm saying it correctly, blemlanibab. And so, Shawnee laughs, yeah. So we will be receiving, we believe we will be able to receive 7 treatments per week. And so our medical staff, nursing and pharmacy is working on how to administer that. That is an outpatient treatment. It's for individuals that there are very specific criteria in order to receive that. You have to have comorbidities, and then it's within, I think, 3 to 10 days of onset. So, but we will have some courses that available to our community. The vaccine, Dr. Arth alluded to, again, the COVID vaccine. So I do want to speak to both the state of Nevada and the state of California. So I'm going to start with the state of Nevada so you're aware, Incline Village Community Hospital. Just a reminder that a lot of what the implementation of the vaccine and who receives it starts at the federal government, comes down to the state, down to the county, and down to us. So in the state of Nevada, Incline Village Community Hospital is working closely with Washoe County. In fact, we've signed an MOU with them. Part of the reason for that is storage. Some of these vaccine need ultra low storage freezers, and we do not have that available at Incline Village Community Hospital. So in collaborating with Washoe County, they will actually hold the vaccine for us, and then they will bring it up when we're ready to use. There's a lot of criteria in the use of that. Once you thaw it, you have to use it within 6 or 7 days. Once you mix it, you have to use it within so many hours. But we have worked very closely with the county along with the local fire department over there in preparing for giving our frontline workers their vaccine, and then again, going through our community. There are multiple phases regarding giving this vaccine. And again, as I mentioned before, the states are telling us who gets it in the healthcare first, then who gets it in the community second. So that is how we are moving forward with the state of Nevada. And we do believe, based on the information they have given to us, that probably sometime in December, we will begin to start with the first line healthcare providers. That does not mean all healthcare workers. It means the frontline providers as they defined it, along with paramedics and fire and police department. For the state of California, it's a little bit different in that we will have to receive the medications ourselves. And so we did go ahead and order some ultra low freezers in anticipation that we would have to store it ourselves. Otherwise, we would have to use dry ice for storage. And so we will have that available when we do begin to get the first vaccines. And again, we will be notified how and who gets it first. Again, the frontline healthcare workers, they will tell us who that is, and we will provide that to our frontline workers. We do anticipate also that group, we will get the vaccines for sometime in December, and then it works its way through 4 phases. It may not be till March, April, May, June that actually the community receives the vaccine, but we hear more about it every day. So that is what is happening with the employee and the community vaccines.
Judy, I have a question about that.
Yes.
And it's also about testing. Recently, I've been told that for some people, when they get tested, and it might be Y or something, that they have to pay for their COVID testing. Oftentimes, these are people who are traveling and need to be tested for that. And is that something that's happening here in Truckee? You know, the community or the county is one that gives it free, but are we testing, and is it covered by insurance for those who have insurance, or how is that being handled?
So you're talking about asymptomatic testing.
Yes.
So we did, I will be honest, we did talk about a few weeks ago about how can we provide asymptomatic testing to our employees. And we did come up with a plan. We have put that on hold temporarily because we are so, we have to set our priorities, and currently we have so many individuals that are symptomatic and requesting to be tested. Our hotline currently is receiving anywhere from 200 to 300 calls a day of people who are symptomatic or would like to be tested. But it is our goal to really meet the needs of our community, and once we make sure that we get all of the patients that are symptomatic, we'll relook at the asymptomatic testing. If an insurance carrier covers it, I would say that depending on their own insurance, if it's going to cover asymptomatic or symptomatic testing.
Okay.
But we know it's important.
What about the vaccine? Is that going to be covered by individuals who want that, or is that part of the national program?
We have not dived into the cost of the vaccine yet, and what that will look like to the community.
Thank you.
Okay. Judy, I've been asked by a number of community members, once first line workers get the vaccine, what has been the discussion about who gets it next?
Yeah, I'll try to, I don't have it in front of me, but I'll try to think about it. I'll try to do it off the top of my head. It is not perfectly defined, but phase one, there was a phase 1A and a phase 1B. Phase 1A is the frontline healthcare workers that are defined. And then phase 1B, I believe, are those people in the community that have comorbidities. Maybe they're older, or they have some other comorbidities. And then there is phase 2 and then phase 3. I think phase 2 is also age related, and then phase 3 is more of the community.
Gotcha. Okay.
But I think part of that is, you know, the availability of the vaccine. So there is limited availability, and we will be offering it to our employees, so they will, you know, make the decision if they want it or not.
Okay, and the plan for distribution is going to be handed down to us. We're not going to make a decision as a hospital or a board or...
No, it is very succinct. And we actually have a task force that is working on the distribution to the community, how that will look, because what you have to understand is, so if we have a 20,000 population, are we going to have 15,000 people that want the vaccine? Are we going to have 10? Are we going to have 20? So we are preparing with the assumption we'll have a large amount of people. And we are actually working, so you know, with Nevada County, the town of Truckee, along with the airport on, you know, where we're going to locate that, because we want to be able to make it easy for our community members to have access to it.
Gotcha. Good.
So it's actually quite a project. Onward, I just do want to talk a little bit about a surge. So we have seen, you know, most certainly Harry spoke to our numbers on an outpatient basis, and you know, we have seen a few more patients in their hospital, anywhere from 0 to 4 or 5. I think today we have 3 patients there. And so just so you are aware, we do, for Incline Village and Tahoe Forest Hospital, have a surge plan. We are required to report that to both states. We, along with that, recognizing the importance of understanding our staffing and being prepared for that surge plan and the number of patients that we can take. So we can expand our beds. We, by the way, have rented beds that we are storing in case we need to increase our patients in case we need to have those extra beds. And I actually think I would like to refer to Karen Buffone, CNO. I know she's been working on staffing, and maybe she can talk about what the staffing plan is and what all the directors are doing in preparation for that.
So in regards to a staffing plan for a COVID surge, we have hired temporary staff to backfill the positions that we have, both for an increase in patient load and for any healthcare workers that may go out under quarantine for a period of time. Each of the directors was asked to come up with a number of temporary staff that they thought was going to benefit the surge in their specific departments. In addition to that, we also have relationships with traveling companies, and we've worked with HR to ensure that those companies have us as a high priority in the event that we would need travelers. The amount of time that would take to fill is approximately 1 to 2 weeks. So that is our current plan, and we're holding with that.
Thank you, Karen. So the other thing is we do monitor daily our PPE, making sure that we have plenty in stock. We also have been working recently on making sure that how we manage the PPE and that capacity. And Shawnee, maybe you can speak to a little bit more about some of the discussions that have happened this week.
Sure. Thanks, Judy. A couple things, right? To go back on staffing, I just want to make sure you guys all understand that Dorothy Piper and her crew have been helping the medical staff with disaster privileges so that we can potentially step into a little bit different roles if need be. We would be stepping into roles that would be similar to a resident and an attending physician where we would report to, for instance, as an OBGYN, I could see hospitalized patients and report up to our hospitalist that tends to do that care and work in a collaborative teamwork fashion if our census gets high enough that we need to pull our resources together. As far as PPE goes, we are currently using all the PPE. We have enough allocation for all the PPE that we need. We are, however, being good stewards, and any time we can recycle, send our N95 respirators off to a Center for Sterilization. We are then housing those N95 masks off-site in and storing them with the ability to use them in a dire situation. So we are currently not reusing N95 masks, which tend to be were intended to be a one-time use situation, but we are going through a process so that to ensure that we always have the PPE needed to protect our staff by keeping those aside and using them only in an emergency situation.
So Judy also, and Dr. Cole, is our supply chain in place that they're well off with production of PPE? I know that there has been some discussion just about supplies, not necessarily hospital, but you know, they anticipated this, so they upped their production. But I still have to say, some shelves are empty of toilet paper already. So just.
Yeah, our director of our supply chain has been very proactive over the last 4 to 6 months, making sure that we have plenty in storage, anticipating, Alice, just what you spoke to, Director Wong. So, and I think the other thing that we're able to do is we work with the counties. So if we do have a shortage, Washoe County, Nevada County, Placer County, we do work with them. In fact, we just received an email from Nevada County during the board meeting, again, just reminding us of our different opportunities and where to reach out if we have a shortage of supplies.
Just a comment for Harry. With the development of our collaborative or collaboration with the other hospitals? Has that group discussed about shares and what they're going to do with the surge if they need help?
Yes, we have talked about it. Carson City is being hit on pretty hard right now, as is Reno, and we've talked about sharing amongst ourselves if possible, and of course coordinating with other hospitals as well. So it has certainly increased our dialogue. You know, one of the issues that many of them are talking about is just personnel availability, and so I think Karen's comments earlier are really important in terms of our plans to try to make sure that we don't run out of personnel. But I think any facility, you know, could run low, and I think that probably our facilities would even be willing to maybe share a little bit here or there if that need arose too. So it's certainly still evolving.
And we did purchase, so you're aware, we did purchase a 3D printer so we could do our own face shields. We do have some reusable some supplies that we can reclean and reuse. So in preparation, if there's a supply chain disposable issue.
So the state has regulations on the number of patients per nurse. Do we assume that those requirements would be relaxed under these dire circumstances?
So this is Karen, and there is a waiver so that we do not have to maintain ratios. So as long as that waiver is in place, it's important to know that we have been able to maintain our ratios, and that obviously has an impact on the overall morale of nurses and their workload.
I'm glad to hear that, Karen, because I've heard that, well, we've heard about the burnout with physicians, but I hear that COVID has really affected a lot of our healthcare workers in the fact that it's a constant with them, the stress of doing it, and just emotionally being distraught after every shift with, you know, gowning and using all the PPE. So I'm glad to hear that we're able to keep those ratios and trying to support the staff through another surge if it happens.
Well, on top of that, Director Ron, maybe this is the time that Alex, our Chief of HR, could really speak to what we're doing for the staff regarding that stress.
Thank you.
And could Alex include in that what kind of cooperation we're getting from the union?
Oh my gosh, sorry, yeah. You know, we're doing a ton of stuff. We've held, so as you guys know about our peer support committee, which we've been training since we created this group before COVID, which is really great. We've got many peer supporters. We have hosted several resiliency rounds and courageous conversations, which has really been beneficial to those people that have participated. They, you know, I'll tell you, it's just an opportunity to express your feelings, you know, and people need that. As you guys know, healthcare workers have often just shoved their feelings down, and they see a lot of things they frankly shouldn't see. You know, it comes to healthcare personnel, firefighters, EMS, police officers. You see a lot of things that you just, normal people don't see. And this is an opportunity for them to get with peers and just talk about that stuff. You know, it's tough. On top of the courageous conversations, virtual meetings we've had, the resiliency rounds that we've had, our wellness group, Wendy Buchanan and others, have a workshop called Mindfulness in Emotional Resilience, which is really an opportunity for people to recognize how they can help themselves using mindfulness, using breathing techniques, shifting their perspective, recognizing gratitude, which is really, really important in I'll just say 2020 in general. As we look at, you know, gratitude, we need to focus on those things that are positive in our life. And so we've been doing a lot of work with that. Our peer support committee members are all trained. They've been trained for talking with peers, not saying the wrong things, which, believe it or not, is a big deal. You say the wrong thing and people get turned off. I'll also say that, you know, as a peer supporter myself, and as somebody that's gone through the training, and somebody that's just a people person in general, I gained so much knowledge going through these trainings and recognizing that some of the things I've said in the past maybe weren't the best things to say to somebody that's reaching out for support. And, you know, you meet with people and you talk with people and you think you're saying the right thing, but those things you say just aren't good. So we've been through training and those have been very helpful. On top of that, I will say that our peer supporters are very ready to help everybody in need. And so we've done a lot of communication around peer support. On top of that, I will say that our employee assistance program through CompPsych is very, very valuable. This brings you to a whole different level of peer support where you can talk with counselors, you can get resources, even if you're, you know, the reality is that just because COVID is happening, life is also still happening. So people are going through tough things. Maybe they're going through divorce while 2020 is happening. Maybe they're going through the death of a loved one while 2020 is happening. All of those things require even more than a peer supporter. And we've got our employee assistance programs to support those folks as well, whether they need psychological help, whether they need help with an attorney. Our programs that we have involved or have for our employees are ready to go, and people can reach out anytime. They can utilize those resources anytime. And we're just continuing these programs. I'm happy that we're part of the Northern Nevada Peer Support Network, which allows us even more resources for our employees. And so I can never say we've done enough because there's just so much that could be done. But I'll say we have done everything in our power at this point to support our team members that are going through so much, not only at work, but also at home. And I know, you know, everybody here knows the stressors that staff are going through right now. It's tremendous, it's remarkable, and we just really want to be there for our employees.
Thank you.
Any comments about the
Harry,
union, Alex?
Go ahead, Harry.
Just a comment about the union support that was part of Mary's question.
Alex,
the union question.
I'm sorry, I didn't hear the union question. I apologize.
Mary wanted.
Basically.
Yeah, we're asking our employees to do so much, and sometimes to move from an area to switch shift to move around the hospital in areas that they might not have been otherwise. And I'm just wondering how much support we're getting from the union in terms of being able to ask our employees to make these kinds of exceptions.
Yeah, so can you hear me?
Yeah.
Okay, so sorry, I'm doing the phone and the computer thing at the same time. So, you know, the unions have been very supportive of this whole pandemic, and I apologize if I went on a different tangent. The unions have been great. They've recognized that we need people to move into different areas. I'm really supportive that they have worked with their constituents and made sure that they're supported as well. We also have, as a great organization, have done good things for our employees to make sure that those people that are stepping up, if you will, are supported, and they're not going to lose their seniority, and they're not going to lose, you know, any benefits or any other things, to make sure that when they step into a role that maybe is not what they signed up for, they are ready, or they are supported, and we're going to treat them right and do the right thing. So the unions have not been an issue in this area at all. I appreciate that.
And Director Brown, perhaps I could just add a little bit to that. If you recall, in March and April, when we first began the pandemic, we didn't really know a lot about COVID. And so our reaction initially is, if you recall, we shut a lot of services down. But we have learned a lot about COVID since then. And we all recognize now that we can continue with services by masking, hand washing, and social distancing. So originally, when we closed services, we moved staff around. Currently, we continue to have all of our services open. We are monitoring, our employees, again, just re-emphasizing to all of us outside of the work environment. That's, those small, I don't need to say it, we've all heard it, the small gatherings, et cetera, really, our biggest challenges, and then employees come back to work. So, we will be monitoring different areas and, watching, making sure we have the staff available. If we have staff out, we may have to, for a day or two, slow that service down, but really our intent is to be able to keep people where they usually work and to continue to keep those services open.
Wonderful, thank you.
And, if I could just add that, we've been doing a lot of work on adding temporary staff. We're very, very lucky that we're a great organization to work for. And what I mean by that is that many of the folks we're looking for are beating down our doors. They want to be part of Tahoe Forest. And because of that, we're able to fill some temporary jobs where it's temporary per diem, temporary part-time, or even full-time. And those folks want to be part of our organization. So they're coming in as a temporary basis, and we're putting them kind of on hold so that if something comes down the pike where we need to activate those staff are ready to go. They're trained, they're ready to go. On top of that, we're looking at adding, we've maintained a candidate pool with videos of them, so that as soon as we're ready to onboard new staff, we have a candidate pool that's so large, we can just pull from those resumes and activate those staff, and we'll be able to maintain our current staffing, if not higher staffing because of a surge, within a week. It'll be really fast, just because we've been maintaining this database, and it's good. So I'm actually really proud of my team for recognizing the importance of this. So thanks.
But also, Alex, excuse me, Karen spoke also about having the connection with some travel agencies. Do we have this candidate pool that you're talking about separate from that, so that at some point we may not have to pay for travelers?
Yeah, we do. As a matter of fact, we learned early on that traveling agencies were charging a lot of money. I mean, we're talking $200 an hour for a traveling RN. And so that's when we started to ask our management team, what type of staff do you need so that we can start getting these people ready and onboarded and trained so that we can activate them at any time. So we went out and did a bunch of recruitment, and then I don't want to say onboarded them, but got them ready so that as soon as we need to pull the trigger on hiring more staff, we have a pool of resources that is ready to go. And we can onboard them, get them ready to go as soon as possible. And we're very lucky, and I know this is a public meeting, but we're very lucky with our closest competitors in our area, I'll say, that we pay the best. We have the best benefits. And on top of that, on top of the benefits and the pay, we're just frankly the best organization to work for. So many people want their foot in the door. And because of that, we, in this pandemic, have a large pool of resources that we can count on to come and help us out. If I just give you a quick example, if you've got organization A that's in Reno and Tahoe Forest, which is in Truckee, as you know, and all of a sudden we say, hey, we need a nurse to come and work, 40 hours a week. Well, that candidate is going to choose Tahoe Forest simply because we pay by far better wages and benefits. So they're not going to say, oh gosh, I'm going to go and work for this company. They're going to come and work for us. And that's because of how great of an organization we are. So yes, we've been.
And because we're the best place to work.
That's right. Best place to work.
Director Wong, if I can just close by saying that, you know, we continue to have an incident command. We are now going to be meeting weekly. All of the administrative council is part of that incident command, plus other physicians and staff. And we did implement last week, in which Dr. Cole, our CMO, and Karen Buffone, our CNO, and Scott Baker, our VP of the Multi-Specialty Clinics and Physician Services, and myself, we actually are now meeting every morning for about 15 minutes, 8:15 to 8:30, just to say what's going on, so that we you know, understand the importance of agility as an organization and to make sure we stay current. So it's a very strong team that we have at the health system, and all the staff and medical staff that really are agile and really working to meet the needs of this community during these difficult times.
Any other presenters, Judy?
No, any other questions?
Mary?
Yeah, Judy, what are we doing this time around with the ECC?
I'm going to let Karen Buffone speak to the ECC.
So the ECC currently has 27 patients. There are no COVID positive patients in the ECC itself. That COVID unit that we ran the first time around is now part of a 7-bed mitigation plan that is part of a regulatory requirement by CDPH. So we are keeping those beds available in the event that we would have any COVID patients in the ECC. So the ECC is running strong.
So we're not going to use part of that facility this time for overflow or any of that?
No, what we found the first time around is, you know, we had the COVID patients over there, and what we learned is that most of those patients need to be monitored. So despite the fact that it has probably the best or most closed off air circulation in the hospital, it does not have the ability to have centralized monitoring in those rooms. So it really, it will serve us better to keep those patients in the hospital. Plus, we have to have that area for the ECC residents in the event that there would be an outbreak of COVID.
Great, okay, thank you.
Sure.
This question, Harry, may be directed at you, but open to anyone. We may have a new president in a month or so. Is there anything on your radar as far as, you know, that change in administration? Are there programs that are at risk of maybe getting cut, or, you know, emergency declarations that might change? Or what are you hearing, you know, as far as that change in administration? Is there any impact on us potentially?
We're not aware of anything really short term. I think that some of the broad agenda items that they've spoken about over many months, such as, you know, Medicare for all, or, you know, just a variety of other things, we're certainly watching those kind of things. I think it's, there is the potential to see more either state or federal initiative programs going forward. I think probably trying to close the gap on a slight increase of the growing uninsured as well. So it is something we're going to watch, but we don't have any short-term negatives. It's just we've got to understand what they really have the political power to make the changes on.
And my question was really more specific to COVID, not necessarily, you know, broad changes to the practice of medicine.
No, you know, we think there might be like a mask mandate or other things. I'm not really aware that they're going to change any of the, maybe the vaccine protocols or things like that. I think they're probably going to continue a lot of the practices to date. You know, they might speed something up, but we're not anticipating major changes relative to COVID right now.
Thank you.
Any other questions from our board? Okay, seeing none or hearing none, any from our audience? No. Well, thank you guys so much for your presentation. And if we do as well as we did at the beginning, I think we're gonna make it through it very well. And Judy, thank you so much. I know I sent you some questions and you've answered all of them, and I appreciate that so much.
Thank you for sending them ahead of time. That was helpful. Thank you.
All right, moving on now to our board actions. We have one item and it's resolution 2020-08. And we have our CFO, Crystal Betts, and I think Matt Mache, our general counsel, is going to address the resolution to us.
Yeah, good evening, board. This is Matt. This item is simply a resolution that's being brought to you again. It was originally brought as a resolution that gave signing authority to our CFO for a loan. And what's happened in the meantime is we wanted to extend the schedule of that loan to add a number of payments and extend the term of it. At the same time, the bank that was in charge of the loan changed hands and switched to a different bank. So with the new bank, they are asking for a new resolution that can provide that signing authority. So this is the reason why we're bringing this back as a new resolution. And I apologize. Our board clerk pointed out to me that some of the titles of board members may be incorrect, held over from that original resolution, but nonetheless, the motion should be the same and should be accurate as to what we're asking for tonight.
Alice, if I could chime in.
Sure.
Okay, thank you. So when Matt's talking about the payments, it's the reimbursement payments, not debt payments. So what we're trying to do is during the period of COVID, we stopped all capital purchasing, and that didn't allow us enough time to purchase all the equipment we said we would underneath this municipal lease. And so I've asked the bank if they'd be willing to extend the time frame in which we could access the funds that are in a trust account that will reimburse the district for equipment purchases that we make. And in order to do that, they needed this resolution to extend the time frame for signing authority. So I can sign the reimbursement requests, submit them to Opus Bank, which is now Pacific Premier. They can approve them and then transfer the money out of the trust account to the district to pay us back for those equipment purchases. I believe we should be able to use the $1.7 million that is left in that trust account that's sitting on our balance sheet by June 30th. So that's what we mean by extending. It's really just a date and signing authority.
Could I mention here that certainly any of you board members are welcome to ask additional questions, but I will mention that yesterday the Finance Committee met, Mary Brown and me, along with Crystal and Harry, and we reviewed this in some detail and asked a number of questions. And as a Finance Committee, we do recommend approval.
Thank you, Dale. Any other questions? So mostly we're doing this just because, well, we're doing this because the bank changed.
Yeah.
Okay. Well,
and to get an extension of time to use the funds.
Right.
Right. So if we did not do this extension, they would take that $1.7 million and apply it to our outstanding principal on the debt, and we would no longer have it available. So by requesting an extension of time, it leaves it in that trust account and allows us signing authority to continue to draw on that until June 30th.
Okay. Any further questions? Any questions from our audience or comments? Hearing none, can I have a motion to approve the form and authorization, the execution and delivery of an amendment that certain master installment sales agreement by and between Opus Bank and the district, and approving certain other actions.
I so move. This is Art.
Okay. Could I have a second?
I'll second.
Okay, so it's been moved by Art, seconded by Mary to approve the resolution. Martina, will you do a roll call?
Director McGarry?
Aye.
Director Shamblin?
Aye.
Director King?
Yes.
Director Brown?
Aye.
Director Wong?
Aye. So the motion carries, and we approve the form and the rest of the resolution. So thank you. And then 18 is discussion of consent calendar items pulled. And if I had known this meeting was going to last this long, I wouldn't have pulled them. But they're not. It's not going to take a long time. I did pull the CMOs, and it was mostly in relationship to that they're still looking at growth and recapturing out migration. And my question to Dr. Cole was, as the staff, it's a medical staff and administration looking at the right size of our healthcare system in terms of physicians and providers as our community has grown, that we're still searching.
Yes, absolutely. And, you know, I work very, very closely with Scott Baker, our VP of Provider Services, and he is kind of instrumental in really understanding the operations of providers and how far out they book and how that indicates when we should start hiring. So I'm going to hand this off to Scott Baker.
Yes, good evening, everybody. We look at this constantly. We look at everything from out-migration data to referral patterns to patient demand and community needs assessments. So we're looking at those data points fairly regularly. And as Shawnee mentioned, we traditionally look at the third next available. That's kind of an industry standard for wait times. And as those start to flare up, and recently, for example, primary care, they have really started to flare up given the in-migration of people into the community. So we're looking at this pretty constantly. I can tell you that once we complete the physician onboarding for those providers that we have kind of in the queue right now, and as well as a couple of recruitments that we have, we will be out of physical space to continue to expand the clinic services, but we're looking at our master plan and pushing those projects forward as fast as we can. So to answer your general question, yes, we monitor this. I would say monthly we look at the data, and every quarter we adjust our recruitment strategy based on that.
So currently the priority is primary care.
Primary care, we have another neurologist. That is a big demand for us. We're also looking at our urology service line and cardiology. We're looking at additional providers in those areas. But yes, primary care is probably our biggest recruitment effort right now to try to shore up the demand that we're seeing by the people moving into the community.
Thank you. And then my other question was, knowing that space is limited and space is valuable, what kind of alternatives have we looked at in terms of utilization of what space we have? Have we looked at extending hours? Have we looked at weekend, any of those?
Yes, we're looking at all of those. You'll hear about a plan where we're trying to put the final touches on in Incline Village, for example, to combine some clinics to open up some space. We're constantly looking at additional space in the community, as well as weekend hours for those that are willing and able to work weekends. So all of those things, all of those ideas are on the table.
Mm-hmm. Okay. Does anybody else have any questions in regards to the CMO report? Because you've answered mine. Okay, then I'll ask Jake. I pulled the CIO's report, and it dealt more with, and he sort of addressed it in safety first, was that Security Operations Center, Managed Services, and the SOW. And I wanted to learn more about what that entailed. Cybersecurity certainly is one of our primary concerns. And now we're looking at managed services. We're looking at their security as part of ours.
Yes, so
in my report, I mentioned that we're looking at a SOW, which stands for Statement of Work, through a company called CI. They are what's known as a SOC, a Security Operations Center. It's a 24/7 group of people. So instead of hiring, what was that, a cattail? It's cat. It threw me off. Instead of building our own 24/7 SOC, we are looking at purchasing this as a managed service through that company CI. They specialize in this, and this is what they do for many organizations. They manage, they monitor your network, and then they manage any kind of threat response that may happen after. So if something's in 3 a.m. and we're getting bombarded by some Eastern European IP address, they will see that, and then we can act on it. We currently don't have someone watching our network 24/7, so that's something we want to address here. So that's what that sentence or bullet was about.
Oh, that's good to know. And then about the pricing transparency, a little bit more information. You don't have to give me a lot, but is that going to be on the web and open to the public to see?
Yes, and I can't give you. I'm not the price transparency expert going on here. But luckily, I work with one of the best CFOs in the business, so Crystal can jump in and correct me. But we've partnered with a company called Para, which will be a price transparency website that's branded for Tahoe Forest, and it will be accessible. We'll post that link on our home site. You have to make at least 300 shoppable services in a consumer-friendly manner. Shoppable service means a service that can be scheduled by a patient in advance. That includes 70 CMS specified and 230 hospital selected. So that's what will be on that Para website. I don't know if that.
Are we looking at a time frame for that to happen?
Yeah.
January 1st.
January 1, right.
Yeah. First of the year.
Okay. Okay.
And the project is on track. I don't see any issue with us hitting the January 1 date. This company has been outstanding to work with. So.
Okay.
Good.
I know it's something that the community has been always wanting, is to know ahead of time what their a projection of what they might be paying for. So thank you. And thank you, Jake, for getting that going, or both of you for getting it going, but also sharing that with us. Does anybody have any questions? I know in the future, we're going to be talking more about transparency. Crystal?
I just wanted to mention that we did do an education session on this in Finance Committee, and that it's also one of the education sessions that's, I think, coming forward soon for the entire board. So more to come on this.
Yeah. Yes, thank you for that. Okay. Then do I need an action or a motion to approve the 2 reports that we pulled?
Yes.
So moved.
Yes, you do actually. Just like consent calendar,
Yeah.
You can move them in one motion.
Okay. Again, Gary shook his head yes too. So can I have a motion to approve the board reports from the CMO and the CIIO?
So moved.
And a second?
I'll second.
I'm sorry. Okay, so we've got a motion by Dale and a second by Michael to approve the 2 reports. Martina, can you do a roll call?
Director McGarry?
Yep.
Director Shamblin?
Aye.
Director King?
Aye.
Director Brown?
Aye.
And Director Wong?
Aye. So those 2 reports are approved. We've had 2 board committees. So Quality, can you give us your report from your meeting?
Yes, Alice, thank you. Yes, the committee met on November 12th, and as we have in the past, we had a patient come to speak to us about his experience receiving care in our system. And we've encouraged this because, you know, we've heard both good and bad stories. But it's always important that we learn and we improve our processes. And this is one of those instances. Actually, this was both a good story and a not so good story. This gentleman, much like many of our friends and family, have been having, at least at my age, been having pieces and parts replaced over the course of time. This time the gentleman came into the facility for a total knee replacement, but he's had experience, as I mentioned, in the past. And in the past, he's had problems with both anesthesia and pain medication. The surgery went well, but because of his previous problems, he remained in the hospital overnight to be observed. Again, everything went just fine. But what he wanted to relate to us was his experience with his discharge. Because of the degree of pain medication that he was on, he was in such a foggy state at the time that he was leaving the hospital. And because of the COVID restrictions, his wife was not involved to the extent that one maybe would have wanted. So they felt they really didn't have a clear understanding of what to expect when they got home. And when they got home, things began to quickly go south. They both hastened to add that every time they spoke with someone who was involved in his treatment, they were kind, they were responsive, but nonetheless, they had frustrations during this time, and they wanted to share those frustrations, and they also wanted to give some suggestions about how we might improve the process, including expanding the discharge instructions themselves, including the caregiver in those conversations, and perhaps the use of FaceTime. So Karen was there, and she was writing everything down and what have you, and I understand was sending out a blast email at that time about discharge and some improvements along the way. We concluded the meeting in his presentation with the fact that, with his comment that he had walked 4 miles that day. So obviously the knee replacement was successful, but he did have these suggestions, and they were heard loud and clear, and I think going to be utilized in some fashion within the system itself. So I think he felt very good about that, and I know we did as a committee as well. Any questions about that part of the presentation of the gentleman? Or okay, well, we went on after that, and we heard from Hillary Ward about our journey to become a high reliability healthcare organization. We've been on this path for about 2 years now, working with an outside vendor, and we are about to graduate. Almost all of the leaders within the organization have been provided with some level of training, and a high reliability team of, I think, about 8 individuals has been put into place. Our next step is going to be to use those individuals on the HRT to train others, and we will become more or less self-sustaining in this endeavor. This is an effort that has been headed up by both Hillary Ward and Alex. Alex, I don't know if you're still there or you want to comment at all on it.
You know, high reliability is something, it's a great initiative. I mean, all it does is help us. It allows us to look at things differently. It allows us to make decisions based off of risk. And it's just a really great thing. I mean, there's no downfall to it. We've been on this path for a long time. I'm a little caught off guard, so I'm not prepared to speak to it. But you know, we've been on this path for a while, and I will say that I have to give credit to Hillary Ward, who's consistently pushing that button, making sure that we're staying on task. And you know, it's really helped us in a lot of ways to, rather than look at things based off of outcome, which often we go to because that's our society, is we look at the outcome and then we decide the fate of somebody. We look at risk and the choices that people made, and it's a great thing. I mean, you know, so again, I'm not prepared to speak to it, but I'll just say that it's really phenomenal. I mean, I'm really proud of the work that team has done, and how much help they've given us throughout this, even this pandemic, you know, making sure that we're focusing on the risk and not just on outside sources. So it's been really good.
Well, Hillary said she'll come back and speak to us again when things settle down a little bit, and we can maybe bring that back to the full board. But it is fascinating concept.
It'll be a constant
Mary,
journey we're on. Shawnee?
Sorry about that. Mary, just wanted to let you know there's 20 plus people on the HRO team, but there's a smaller group, you're right, like 6 or 8 that will be teaching the rest of the organization. So it's an amazing group of people that crosses every single department, from facilities to lab to radiology to physicians to nursing to pharmacies. It spans the entire organization, and there's people from Incline and people from Tahoe Forest. So it's quite a big group, and they've been quite vigorous during this whole process, including outpatient clinic setting, inpatient. It's been amazing.
And I'm sure that when Hillary gets her presentation, we'll hear more about the team and all the progress they've been making.
Absolutely. Thank you for that, Shawnee. I appreciate that. And
Anything
then,
else?
yeah, one last thing. As part of our committee education, we discussed the Cures Act, which went into effect at the beginning of the month. That has to do with the patient access to physician notes within their medical record. We talked about the pros and the cons and the advantages and the pitfalls that might result from this particular act. Shawnee, I think you mentioned in your narrative this month that you might be working with the Patient and Family Advisory Council on this and consulting with them and getting their advice as to how patients might receive this information.
Yes, that came up in the board quality meeting, was to make sure that we understand the patient perspective when they're reading potentially a very technical note written by a physician that's a scientist, but being read by the layperson. So how could we maybe message to the public from a patient and family perspective on this?
And isn't that one of our educational sessions, the Cures Act for 2021?
Yes, it is.
Okay, so we'll be hearing lots more about that, and then what our district is doing to make sure that the clients that use it know what they're looking at.
So that concludes my report, Alice, unless there's any questions.
Thank you so much. Okay, then.
I could.
Do we have a report from Finance?
Yes, as I alluded to earlier, the Finance Committee did meet yesterday, consisting of Mary Brown and me, along with Crystal and Harry. And we focused primarily on our ongoing concern for billing and AR. I'd like to reiterate that Mary and I really appreciated you sharing with us the EPIC data that's available that was not highly complimentary of our work to date. And we're hopeful that we can use this data to plot a trend line. We're going to plan to meet in February and see what kind of progress we're making. And but we think we're headed in the right direction. As you know, we have Epic through Mercy, but Epic has stepped in directly to assist us too, because we're not coming along at a speed that they would hope we would be coming along at. There was some pushback from Mercy initially, but Mercy's bought into it now too. So anyway, there's light at the end of the tunnel, and Harry, we really do appreciate the fact that that information that was, as I say, was not highly complimentary, was shared with the board or with the committee. So anyway, more to come in February.
Yeah, we can always do something better, and it sounds like they're working on it.
Yep.
Okay. Do we have any comments from any of the other boards or reports? Well, is Ted still on the line? So Ted, remember how we were timing meetings and I had the shortest meeting? I think I'm at the longest meeting now.
2 hours and 35 minutes, yes.
Yeah, yeah, okay. So I have both awards. But if no one has any other comments or remarks.
I can remember 11:30 meetings.
Yeah, there were some midnight meetings there back in the day.
5.5 hour meetings, yes.
Yeah.
Okay, we won't go into that, but we will.
Don't try that.
Yeah. Thank Gary Bell. Yeah, you know, David owes you for this meeting. So thank you guys. Happy New Year, happy Thanksgiving to all of you. And we'll adjourn the meeting.
Thank you.
All right, thanks.
Everyone.